So for starters, does someone have some questions they want to ask? Just throw your hand up or stand up or something, because I might not see you.
So the question was, this was getting at the gate control theory of pain, where when you're injecting Botox, if you press hard, just proximal to the site of injection, you activate the A beta fibers, which override the pain sensing C and A delta fibers. And the person cannot feel the pain of the injection. And the question was, can you use that particular technique for a pericranial nerve block? And yeah, the answer was, for the pericranial nerve block, it's a little bit trickier because you're injecting a much larger volume.
Do you have questions? I will take this to the first one. Question.
Okay, are there more questions? Over here in the front.
Hi, this question is for Dr. Jarvis again. You mentioned about sphenopalatine ganglion block for post-dural puncture headache. So can that be alternative to blood patch? So can the sphenopalatine ganglion block be an alternative to epidural blood patch for post-dural puncture headaches?
I wouldn't use it as an alternative, but I would use it as a temporizing measure until the blood patch takes effect. Definitely.
So let's make Dr. Ameya do some work. And we have some nerve block questions in the back. Is there something? Do you have a question?
Hand up. Could you explain to me how Botox can help depression? I thought that depression is a mood disorder.
Okay, so how does Botox help depression? There's actually 5 different mechanisms proposed. One is by mediating the inflammatory milieu, and that ranges from that end to the other end of the theory. And I've talked to patients who have had Botox injections before. They feel they look better. And if you feel you look better, you project a different image, which is reflected back to you by the people looking at you. And this is, it seems almost intuitive, right? You would think, okay, you feel you look better, of course your attitude would improve. And that actually has been borne out in the research, but it's not the exclusive explanation. There are several mechanisms proposed for that. Yeah. I have a question for Ameya. Dueling microphones. When do you decide to do a facet block versus a medial branch block?
So in my practice with cervical pain, I don't bother doing a facet block at all.
Okay.
Period. I just go straight to the medial branch. And I think that's just because the evidence would suggest doing the intra-articular facet joint injection does not confer any increased positive predictive validity on your diagnosis. So as a diagnostic test, the facet joint injection is not any better than the medial branch block, and the medial branch block is more predictive of RF success. So the thought being that you want something that's going to work for a long time, because as we all know with our pain patients, like a day of relief may seem great, but it's only good for a day. You need to get weeks, months, years, and really that's why the recommendations from SISA and ASRA Pain are to move well towards RF neurotomy. Certainly in a situation where the patient is a pacemaker, they have a contraindication, they're elderly, you don't think they can make like 3 or 4 appointments happen in a short period of time, it's not unreasonable to consider intra-articular steroid injection. But if it's a young person with a neck injury, that kind of stuff, just recommend straight to medial branch block.
Good.
Yeah.
Thanks.
So to put this in perspective, the typical patient where this comes up in my practice is a patient who's had a whiplash injury, and they have a lot of headache, and a lot of it is posterior, some may be in the front, and it all began with a whiplash. Ameya mentioned the diagnostic criteria for cervicogenic headache, but the International Headache Society also has diagnostic criteria for chronic post-whiplash headache, and really the main diagnostic criteria there is that it began after a whiplash injury. So, Ameya, traditionally, we have preached that you do a, so the big levels there are the C2-3 and C3-4 levels, especially C2-3, which you emphasized. And traditionally we taught, well, okay, you do a facet block. If that provides relief temporarily, you do a medial branch block. If that provides relief temporarily, then you look for the ablation.
Correct.
To get longer term benefit. Now, you're saying that the facet block maybe is kind of passé now. We go right to the medial branch block. Do you do one or do you do two? Do you try to confirm the result? I mean, we got a powerful placebo effect there, perhaps.
Right, and so, again, you know, it totally spun on its head when you look at the lumbar spine. So lumbar spine, the evidence would say, yeah, it's okay for you to go ahead and get a facet joint injection, go ahead and get a medial branch block, and maybe if that kind of works, maybe do another medial branch block just to make sure, and then go ahead and get an RF ablation. In the cervical spine literature, they're much more consistently recommending you just go straight for the medial branch block, a single medial branch block, while a second block can increase your increase your certainty from a clinical perspective. It just increases the risk of false negatives, and therefore the recommendation is to go straight from if you have a positive medial branch block, and the definition for that being they have persistent greater than 50% pain relief lasting for the duration of the local anesthetic. So for some patients that could be a couple of hours, some patients could be days, but then go straight to RF ablation. And that's what at least the guidance is right now from SIS and pain medicine.
So life has gotten simpler. Just one block and then the ablation.
Yeah.
Or do you do a lidocaine block and a bupivacaine block and no?
Yeah, that's complicated. I think a lot of that has to do with how different. I'm going to phrase this in a politically appropriate way. I think that a lot of this is guided by our fee guide and our fee structure, but the purist would say that go ahead, just do a straightforward bupivacaine local anesthetic block with less than 0.3 mils, and if it proves quality of analgesia, then go ahead and do the ablation. You may not easily be able to do that, and you may have to jump through some hoops to get access for it in the community, but certainly that's not necessarily evidence-based practice.
Thank you. Other questions?
We got a question over here.
Good.
I just wanted to ask on that question. Like, I thought that if you did the medial branch block and you see the results, you're doing the second medial branch block to confirm that you're not having false positive. And if you have consistent results, then if you were to go to do the ablation, you're more likely to have the same effect in the patient to have pain-free symptoms. And from what I understand, the research out there is like low numbers, but if you have less medial branch block, like if you've done one or none or two, the more reproducibility results showed, more people like 6 months out with pain relief compared to like less testing blocks done.
You're right. Yeah, all of this is about success of the RF neurotomy, and the literature in the lumbar spine has certainly borne out to that, which is more blocks, and even doing the intra-articular injection followed by a block leads to, or is predictive of greater success of RF neurotomy. And the reason for that really is that's a 6 to 12 month pain relief treatment, which is fantastic. No meds, patients have time to actually work on their physical therapy programs while they are in less pain. In the cervical spine literature, though, it hasn't really been borne out in the same way. It would stand to reason that it should be similar, but a lot of it is related to the amount of local anesthetic that gets administered, different provider variability. So if you have a negative block, may be reasonable to consider repeating the procedure, but if you have a positive block, just go straight to the neurotomy. At least that's what the recommendations are. And your practice experience may be totally different, and really depends on your patient too, right?
Thank you. Question over here.
Dr. Jarvis, we here at a Pain Society meeting, and chronic pain is more than a tissue lesion. We've heard two presentations on the role of injections, and then you're suggesting repeating local anaesthetic injections. I wonder the frequency of that or the efficacy in long-term management, sort of risk-reward relationship. Is there anything else can get longer effect? Like, has that approach been validated compared to chronic pain management? So healthcare resource utilisation, a lot to unpack there, but you know, is that something that you'd recommend you repeating weekly, monthly? Is there other approaches to help those people in the long term?
Yeah. When I started doing the procedure, I was the only neurologist at the Rocky View Hospital in Calgary doing nerve blocks, and quickly I was overwhelmed by just doing nerve blocks on patients that I was inheriting from other neurologists. So we're lucky at the Alberta Neurologic Centre now. We have a team of nurses and Ps as well that can take on some of these patients, a large volume of them. Thanks, Anne. The ideal in the literature, people talk about if you don't. Some papers will say if you don't get 3 months of benefit, it's not worth doing. I don't believe that. I think a month is better, and we try and say, okay, 1 month. If you can't get 1 month, there are some circumstances where we'll do it sooner. But I've had people where nothing else works, and if there are people that I've had patients who come down from Red Deer to get 3 or 4 days of relief, just so they can function for 3 or 4 days. So we do it once a week, but it's rare to do it once a week. The minimum usually is about every 2 weeks is as often as I like to do it. Ideally, every 6 weeks so 4 to 6 weeks is what I tell patients. We can get you that with a decent block. To improve that benefit, doing more sites definitely works, and larger volumes as well. 0.5 bupivacaine definitely lasts longer than 2% lidocaine. So, well, 2% lidocaine will kick in faster, but usually we're looking for more of a prophylactic effect. So we'll use the bupivacaine instead. So more sites, more volume, unlike the limit of 0.3 cc's. That's it. In the literature, some papers will report injecting up to 3 cc's, and I don't know how a golf ball size injection helps very much. So there's a really interesting study that was done N of 10 using 10% lidocaine, which is basically neurolytic, ultrasound guided, and the average duration of benefit from the 10 patients was 192 days with a single injection. We have looked for 10% lidocaine. We do have some 4% lidocaine. You can get 4% lidocaine in ampules from a supplier in the United States that you can inject. And 4% definitely lasts longer, but it's hard to get. So until we can find 10% lidocaine here and do a larger clinical trial on that, we're stuck with 0.5 bupivacaine. Yeah.
Thank you.
Hi. I've just got a question about how you guys would take a look at choosing the appropriate client for these procedures if the client, say, had several areas of pain that had lasted for longer than 6 months. How do you sort out how this procedure is going to factor into a more global pain pattern? And just to make sure I don't trap you, it's because this would be just a cog in the wheel. And if you're only getting short-term success, to me, that means that you're not hitting the nail on the head. So how do you guys look at that when you're trying to select which patients are appropriate for this?
So, yeah, I guess I'll take it first. So in general, you know, when I see certain patients in the clinic that have, say, a widespread pattern or a much more diffuse pattern of pain, I tend not to offer procedural management at all. And the reason for that is typically the conservative management can't just be, you know, seeing their physio once in a while or seeing one part of the rehab team. Often it involves them actually having a better understanding of pain neuroscience, how their pain is working, when do they have flares, having the time to actually, you know, not just describe, oh, the pain is everywhere all the time, but no, the pain changes, and these are the times when it's affecting my headache. These are the times where it's my low back. I think having the patient do that kind of homework ahead of time then helps me determine, well, okay, maybe now we should think about offering you an intervention related to your head or neck. Certainly, imaging sometimes can help guide that, especially if this is part of your differential. And you know, patients don't come neatly packaged in a box. They you know, just because they had a bad whiplash injury doesn't mean that they didn't break their pelvis or hip in that same car accident. And so they have leg pain and all those issues. So it is a lot of unpacking, but it's a lot of work ahead of time, I think, in first determining what is wrong, where is it wrong, when is it wrong, how does it flare, how does it back off, and a lot of that is kind of patient-driven and their own homework first before we go ahead and offer kind of just go ahead and get these injections. And I appreciate that not everyone in the community is able to sit down for what can be a 2.5-hour assessment to figure out what's what, break it down and go through that. So, you know, I think this is the ideal, but I also appreciate that it's difficult to do.
Yeah, I would agree that what we're doing is one piece of the puzzle. You know, I'll give you a scenario, chronic migraines, for example. Platform therapy would be Botox or an anti-CGRP monoclonal, and then whatever medications a person can tolerate without adverse effects. And then nerve blocks, if they work, does that buy you an advantage for an appreciable period of time? One of the most common uses that we have in the clinic is for those people who are on Botox or anti-CGRP monoclonals where they wear off. Botox lasts 10 weeks, 9 weeks, so we use nerve blocks as a bridging. And in fact, when they come in and get their Botox at 12 weeks, I will do a couple of nerve blocks in addition to that to just knock that headache down until the Botox kicks in for the next 10 weeks or so. I mentioned my MS patient population. These people don't tolerate drugs at all. And so in these cases, pericranial nerve blocks can become the mainstay of therapy in the absence of any other therapy that's tolerated. Patients at the refugee clinic who can't afford health care insurance, they get free nerve blocks. So that's, you know, there's many scenarios where we use these things, but, you know, to use them exclusively, there's a few people where that's all they want. And if you get 4 to 6 weeks in ICU for 10 or 15 minutes or a nurse, and it works great, then great.
So one place where nerve blocks for some headache syndromes are touted is in pregnancy, because people want to avoid drugs during pregnancy. And I thought the gospel was that lidocaine is safer than bupivacaine for pregnancy. I recently saw a randomized trial where they looked at occipital nerve blocks in pregnancy with bupivacaine. So am I out of date or what? Lidocaine is safer, isn't it?
Yeah, absolutely.
Yeah, I was a little surprised. So
Yeah.
if they're pregnant, use lidocaine. Okay. Dr. Bopardikar, so you emphasize the fact that in Alberta we're so lucky we can order medial branch blocks.
Yeah.
Now my understanding is that when it comes to headache, the big ones are always C2-3 and C3-4 facet joints and medial branch blocks. You did talk about the higher levels, but those aren't generally available, are they? That's tiger country. People don't want to touch that.
Correct, yeah. So generally speaking, that is not easily accessible.
Yeah.
I perform them in my practice, but you know, I practice out of the chronic pain center, so we have I see a far smaller slice of the patients that exist in all of the province. So some people will perform them. There are other physiatrists who have an interest in doing headaches that have an interventional component to their practice that will do them at different clinics. Certainly other pain clinics that have been popping up around the city and around, you know, North Zone 2 in Edmonton may be able to do them. But a lot of that is just reaching out to them and asking, hey, would you be able to do this? Would you consider? So certainly worth asking, and sometimes they'll say, oh yeah, well, we're okay to do that as long as there's imaging available.
So the bottom line is that you can't always access those blocks above C3, C4 that easily.
Above C2, yeah.
Sorry, C2, C3. Yeah, and even though those are probably
The most important.
causing a lot of headache.
Yeah.
So, you know, we're not quite there yet with the science and with what's available. Other questions?
So I'm just thinking about those pericranial nerve blocks. Do you think there's any role for like a topical agent over that area? If you could compound something, with a diclofenac, lidocaine, maybe some ketamine, do you think it would actually be able to penetrate to the place where you would hit that nerve? Because that potentially could be something that a patient could apply themselves.
I have tried topical preparations on patients. There's one that we use. It's 20% bupivacaine, 5% tetracaine, 4% lidocaine. That we tried. It hasn't worked as well on the greater lesser occipital nerves, but people who are actually having migraines have found this to be an effective temporizing measure when applied over the temple, or you've got the zygomatical temporal nerve, as well as the supraorbital and supratrochlear nerve. So we have few patients who have found that cream to be quite effective at least mitigating the headache until they can get home to where they have forgotten their triptan.
Whoop, microphone.
I am me. Question about using the bupivacaine, tetracaine, lidocaine cream. Do you have any guidance? Because we do have patients that use it, as to how much they can use over what period of time. Because I can think of 2 patients, and I don't think they're yours, but I swear they slather it all over their body because they go through so much.
Generally, when I'm talking to people about using these creams, I do BID. Yeah. And it may be more theoretical, but this is a phenomenon that you will observe is if you consistently block sodium channels, you will get upregulation of sodium channels. And this was observed with the intranasal lidocaine sprays that kind of were popular for a little while, that eventually you just need more and more and they become less and less effective. So try and be careful with the creams.
I was going to ask a question.
Yeah,
Sorry.
go ahead.
You didn't really comment much on the slideshow regarding like if you're only getting so many weeks with just local anesthetic, would you ever put any cortisone around that nerve to see if you can get a longer lasting effect?
Me?
Yes.
Oh. There's a lot of clinical trials that have looked at lidocaine, or usually lidocaine or bupivacaine versus lidocaine, bupivacaine, a local plus or minus a steroid. Easy for me to say. And the only scenarios in which the steroid has helped has been cluster headaches. So I will try. If I palpate an area and they have exquisite pain to palpation in that area, and I do a nerve block and it doesn't work, then I'll try a steroid. This came from Liz LaRue. We saw the slide from Migraine Canada. She was the neurologist that started the Migraine Canada. And she said she's found patients who sometimes will actually have irritation over the capitis muscle insertion overlying the greater occipital nerve. And so in people where she suspects that, would inject a steroid. And it may help for muscle inflammation, which may be irritating the nerve secondarily. So I imagine there are scenarios where you could use steroid, but I would never use steroid outside of over the occiput, and never more than every 3 months.
There's a large meta-analysis and systematic review out of MAC looking at using peripheral nerve blocks with steroid, and the evidence actually would suggest that you should not be utilizing steroid consistently, even though that is our practice. When you look at the directed clinical data, steroids can increase duration of local anesthetic effect, but the evidence for that is at a mean of something like, when you'd expect, say, bupivacaine to last 18 hours, you can add on up to 6 hours worth of benefit, which is not consistent for when it comes to pain medicine. That said, anecdotally, I found some patients seem to get 3 months worth of benefit. And it seems to be nerve dependent, patient dependent, and their neuralgia, and whether or not their neuralgia is related to some sort of a compressive neuropathy, or is it actually direct nerve injury due to, say, CRPS or something like that.
Hi there. This is a question for Dr. Jarvis. Why is he so tall and handsome?
You old dog, you!
The second question is, with your SPG blocks, what is your technique for doing those?
I have 2 techniques, one of which I will be demonstrating on Saturday. The easiest one, which I teach my patients to do so they can do them at home on themselves, is to take a nasal swab, basically a wooden Q-tip, and apply 5% xylocaine ointment. You can get both of these things on Amazon. And I demonstrate on myself, but short and sweet answer is you put the swab with a dollop of lidocaine on it, put it inside the nair, and just press it against the septum, advance it 2 centimeters at a 45-degree angle before you level off and head back at 10 degrees elevation. And at about 5 or 6 centimeters, you will hit the SPG. You'll know you hit the SPG, and you can tell the patients you're going to feel this exact thing. If you want to try it on yourself, I've got the stuff. I'll bring it on Saturday. Yeah, I never leave home without it. Headache, you say? They come with me. Yeah, I'm in 1350 coming up after the talk. The sting, you're going to have a little bit of discomfort when you advance that the swab. But the second that lidocaine hits the SPG, all hell breaks loose. The eye starts watering, the nose starts running, and it's a sting, it's a burn. And you tell them, you expect the burn. The second you do, we know you're in the right spot. And we've got a lot of patients now, increasing numbers, where we just get this stuff on Amazon and do it yourself. And it's that easy. The alternative to that, there are a couple catheters that you can buy. I was using one for a while, but the company was asking for $120 every time I did this thing. And I'm not going to charge my patients $120 for a catheter to show up the nose. And it turns out even more effective than a $150, $120 catheter is a 50-cent pediatric bladder catheter. So you can buy 5cc syringe, pediatric bladder catheter, 8 French, and you attach one to the other, and you lie the patient supine, hyperextend the neck, and you advance this. And you can Google sphenopalatine ganglion block, and you will see diagrams of this being done on people. And you basically just keep that catheter as superior as possible while they're lying down. When you get to the point where they start to flinch, you're at the most superior you can go, and then you just eject 2 cc's of viscous lidocaine or 4% lidocaine, whatever, and just have them lay flat for 5 to 8 minutes. So there's probably dozens, I can tell you there are dozens of videos on YouTube of people doing this. So I told you the materials, then I suggest everyone take some time out and go back to your room. But yeah, it's actually pretty easy.
So Scott, that Q-tip, give us the number again. How many centimeters?
People, depending on, you can get a read on people depending on that nose size and shape of the skull. You can approximate. You're going to be between 5 and 8 centimeters.
5 and 8.
Yeah.
So 5 for you, 8 for me.
I think I'm probably more of a 6.5.
And thank you to our 2 speakers.